Bismillah ar-Rahman ar-Rahim. Is hyperglycemia a risk for fasting or not? Glycemic control before Ramadan is essential for safe fasting for people with diabetes. And while exemptions are allowed for those at high risk, observational studies showed that many individuals will choose to fast in spite of their high risk. Prolonged fasting hours and changes in meals and medication timing is challenging for people with diabetes, heightened the risk of both hypo and hyperglycemia. Glycemic control before Ramadan, reflected by hemoglobin A1C level, is a strong predictor of safe fasting. Elevated pre-Ramadan hemoglobin A1C reflects chronic hyperglycemia, higher glycemic variability, and inconsistent self-management by the patient. These factors can increase the metabolic burden of fasting, increasing susceptibility to dehydration-related hyperglycemia and hypoglycemia. Ramadan Alliance Risk Calculator incorporated glycated hemoglobin into fasting risk stratification. In spite of limited evidence to validate the cutoffs of less than 7.5% for low risk and more than 9% hemoglobin A1C for high risk to predict fasting outcomes. These cutoffs were chosen based on expert opinion and clinical experience, so it was important to assess whether these thresholds are clinically meaningful or not. And we did this study, the correlation between pre-Ramadan hemoglobin A1C level and fasting outcomes in individuals with type 2 diabetes, evidence from the global 2020 to 2022 DAR survey. The study objective was to validate the association between pre-Ramadan hemoglobin A1C and key related fasting-related outcomes. Study provided necessary evidence for the risk stratification threshold of less than 7.5 to more than 9% used in the IGF DAR risk calculator, studying variables and risk factors like age, duration of diabetes, the presence of complications and comorbidities, type of treatment including insulin, self-monitoring of blood glucose frequency, and receiving pre-Ramadan structured education. Study design retrospective sub-analysis of the DAR global survey involving more than 11,000 participants with type 2 diabetes from 7 global regions and covering more than 20 countries. Participants were categorized into 3 groups according to hemoglobin A1C level. Group 1 was good control and hemoglobin A1C less than 7.5 at baseline, and Group 2 intermediate control with baseline hemoglobin A1C between 7.5 to 9, and Group 3 with poor glycemic control with baseline hemoglobin A1C more than 9%. And those were the primary outcomes measured: fasting participation and the duration of fasting, if the patient could fast the whole Ramadan, 30 days or not, incidence of hypo and hyperglycemic episodes, fasting interruption due to glycemic event, and severe glycemic events requiring assistance or emergency care. And those were the participant percentage, and those with good glycemic control less than 7.5, hemoglobin A1C, were 37% of the total participants, and intermediate control were 33% of the participants, and those with poor control with hemoglobin A1C more than 9% were 25% of the participants. And these were the baseline demographic and clinical characteristics in the three groups. And let me here mention that the mean hemoglobin A1C was 6.6 in group 1, 8.2 in group 2, and 10.8 in the poor control group, group 3. And those were the baseline risk factors and complications in the three studied groups. And retinopathy and neuropathy was highest in the poorly controlled group, followed by the intermediate group, then lowest in the good glycemic control group. And all antidiabetic medications were used, but when we mentioned sulfonylurea and insulins, we found that 64% of people with type 2 diabetes with poor control were receiving insulin. And when we asked about SMBG by the patient, how frequent were these patients doing SMBG, we found that around 45% of people with type 2 diabetes in the three groups were using SMBG as if before Ramadan, the same frequency. And 25% of those patients did not do any SMBG at all. For Ramadan fasting, the intention for Ramadan fasting in the three groups, in the good control group, 89% had the intention to fast, around the same figure, 88% in the intermediate control group has the intention to fast the whole Ramadan, while in the poorly controlled group, 80% of the patients had the intention to fast the whole Ramadan. But who completed the 30 days of Ramadan fasting? 70% completed in the good control hemoglobin A1C patients, compared to 67% in the intermediate group and 58% lower percentage in the poorly controlled hemoglobin A1C group. When we examined the hyperglycemic events in the study group, we found that hyperglycemic events happened in 3.8% of cases in the good control group, compared to 20% in the intermediate control group and 25% in the poorly controlled groups, and 25% of the patients in the poorly controlled group had hyperglycemic events. And those who broke the fast due to hyperglycemia were 0.8% in group 1, 4.2% in group 2, and 6.4% in group 3. What about hypoglycemia risk? The risk of daytime hypoglycemia and related fast interruption was 2.5 times higher for the poorly controlled group when compared to the good control group. But there was no statistical significant difference in severe events requiring assistance in both good control and poor control groups. Then the hemoglobin A1C threshold can define fasting risk, and the stepwise risk gradient from less than 7.5% to 9% support the hemoglobin A1C thresholds used in the IGF-DAR risk calculator, reinforcing the 9% high risk category, particularly for hyperglycemia-related outcomes where the complications are the greatest. And pre-Ramadan hemoglobin A1C is a strong predictor of fasting safety in individuals with type 2 diabetes, and these were the results of the trial. Poor baseline control is associated with less likely to complete Ramadan fasting and high risk of fasting interruption due to both hyperglycemia and hypoglycemic events. In conclusion, higher pre-Ramadan hemoglobin A1C was associated with lower fasting participation and a greater risk of hyperglycemia and hypoglycemia-related complications, and these results support the use of current hemoglobin A1C threshold in Ramadan risk assessment. Again, in conclusion, results stress on the importance of optimizing glycemic control for people with diabetes before Ramadan fasting. Providing targeted education before Ramadan can improve safety and reduce complications of fasting. And these are the takeaways message. We should do routine assessment before Ramadan to perform hemoglobin A1C 6 to 8 weeks to stratify the risk on fasting for each participant or for each person who wish to fast with diabetes. Targeted education to provide a structured, individualized education to those patients who wish to fast, especially for those with hemoglobin A1C more than 7.5. Management for high-risk patients to consider advanced strategy like CGM or flash GM to modify medication whenever necessary, and for digital health support. And future research should include prospective study needed to confirm whether lowering the baseline hemoglobin A1C can reduce complications or not. Thank you very much.